welcome back to the Borescope Expert series on Beyond Clean. I'm Bobby Parker, and I have with me in studio here your Borescope experts, Andy and Jenny. Guys, welcome back to the show. Today's episode, I want to talk specifically about how to gain approval for implementing a borescope in your facility. Not just why they're important, not just how to use one, but how do you get one in the first place? So could you walk me through maybe what are some of those strategies that you found helpful in presenting the case for borescopes to key decision makers?
So great question, Bobby. A couple things that stick out in my mind, just high level and across multiple facilities from our observations are, make sure you're not tackling this alone. All right. This is a pretty big deal. There's a lot of key players that could certainly be brought in to help understand, what the case is for this. Couple things that come to mind would be, CSSD leadership, endoscopy and surgery leadership, infection prevention. They're always very interested in what's going on inside devices, biomedical teams, regulatory risk management, and one that you might not be thinking about would be your vendor partners. So I'm not just thinking of like a borescope vendor, but I'm thinking of repair vendor, OEM, manufacturer. Jenny, you got a lot of experience on making your process happen. What are you thinking?
First, I just want to say, yes, this can be a leadership-driven decision to bring these in, but it can also be a grassroots by the technicians to bring this in. So either one can use some of these tactics to elevate it up to where it needs to be. And hopefully that's in partnership. I think first and foremost, the patient has to be at the center. Why do we need we need safe medical devices for our patients, and then the risk associated to those patients and also the organizations. Sometimes you can push on that a little bit, like what if we don't have safe medical devices, what risk does that put the organization in? I would say the next big thing is that regulatory compliance language. Make sure you know what is out there. ST91 has an update. There are some shoulds in there, so a should is there for a reason. Maybe some of that research, public safety events, the CRE outbreak, there's stuff out there. Ofsted and Associates has some excellent research that they have done specifically around safe medical devices with channels and lumens. I would say, high level disinfection is, if you are in an organization that's under survey, immediate threat to life findings, like high level disinfection of critical devices or, medical devices is always in the top 5. And again, that's a risk to the patient and the organization. And then you need to know your business case. What is this going to help with? And again, we're going to tackle that in a little bit, but it's really your business case, the why, and putting your patient in.
Yeah, what you're getting at is risk to the patient. So another resource available to you is this Beyond Clean Expert series, right? Send this whole video series over to your decision makers, because last episode we had some great conversations around it's not just a matter of if you're going to find something in your devices, it's really a matter of when, and the risk that you're putting your patients under by choosing not to look inside your devices. You made mention of IFUs as well, not just standards out there, but cleaning requirements of instruments that you might be cleaning in your facility. Andy, have you seen any of those that are starting to require or at least recommend borescope uses?
Yeah, we have. So, I think, and this might be a trend, it might not be, but arthroscopic shaver handpieces, specifically Stryker and Arthrex, those are 2 IFUs that we often get pointed in the direction of. There is language in that IFU that talks about visual inspection inside of the device. And so, that was maybe even done pre-borescope language. But, that's a tool that allows you to do that. So I think that's a great point, Bobby. I know Jenny's all over that as well, is that, Stryker and Arthrex, if you have those devices in inventory, that's something that you might want to even just pull the IFU to make the case.
Yeah, double check for sure. So, Jenny, you mentioned something really interesting, that this isn't only an infection preventionist argument for patient safety, but there's also a business case to be made here. So can you all tell me a little bit more about what this business case looks like? What's maybe the ROI for implementing a borescope in a department?
I'll start it real quick, but Jenny, you hammer it home here. So we're all striving to just make patient-ready devices. Safe devices, quicker turns, lower turn costs, avoiding major repair costs is certainly a big objective. Jenni, your team's done an incredible job on using this to create some ROI.
Yes, it's all about the data and what that is. So to Andy's point, like those big categories, that's all from an organizational standpoint, how quick you're turning your OR around, how many times you have to open, or have a contaminated case, all of that, time is money in the operating room. So all of that equates very readily. Some other data points we use to help, look at that ROI and justify the cost of the borescope or the repairs that we're seeing is, what are your repair cost trends? Minor damage versus waiting till there's major damage, finding something, say, inside a flexible endoscope that you found right after the use where maybe that channel was damaged from an instrument, an instrument going down there and being deployed in that channel versus, where you can get that channel replaced for a minimal cost versus waiting till that is in there, then it's invaded, it's in the scope, and then you have a failure of that scope, and then you're doing a major repair, which is about, at least double to, if not triple to 4 times the cost in the flexible endoscope world. So those repair costs, your trends, what you're doing, are you down instrumentation, your loaner costs, if you have a positive culture and you have to pull that out of service, and what's your culturing costs and sending that out to maybe an OEM to have that device looked at and out of service for, 45 days or 60 days while they look at that and reculture it and things. Your patient impact is your big second bucket of your ROI. What's the average cost for a hospital acquired infection in your organization? Surgery has those statistics. Leadership has those statistics. And a contaminated instrument in the OR, and you give the patient a hospital acquired infection, there is a cost associated to that, down to reimbursement. I mean, there's a whole slew of stuff around that. Failures during procedures, extended times during procedure, alternate procedures they have to do. So that's, again, the second bucket. I would say the third kind of bucket of costs are those organizational costs. And that's maybe just your operating time, your equipment unavailability, canceled procedures, physician productivity, team productivity, surgery time. It's all goes into that. And then there is a cost too to satisfaction. If you're in leadership and all of this and reimbursement, like your HCAP scores and what that is. Well, if you give a patient an infection, or if they had to wait during a surgery, like that all goes down into that organizational costs if that isn't 100% where it should be. And then I would say the last one that we can control really is the reprocessing time. All of those things that we look at in a sterile processing department, how many times did it have to be multiple cleaned? How, if it had to go back and be done, if it got to the clean side and it was still dirty and they had to reject it and send it back. And then, that all of that time is lost time in your productivity. And then if you have to reprocess things, your AER cycles, your chemicals, your washer data, I mean, all of that goes into your costs for operations. So you can really hone in on a lot of those data points to get very quickly to a positive ROI for a device that is a lot less than a GI endoscope.
You're right. Yeah, it feels like a lot of money, particularly for smaller facilities when you start talking about borescopes, but you underline both some hard and soft cost savings. So those hard cost savings, like looking at your instrument repair budget and being a bit more preventive about how you take care of your instruments, can actually reduce the overall burden of your replacement costs. It's really important. But some that sound like a soft case or a soft savings, like imagine the cost of an healthcare acquired infection. There are real cases that have been really tied to real debris and real arthroscopic shavers that had real cost to real facilities. So absolutely, I'm glad that you brought that up. So as you start to make this case, what are some of the common concerns or objections that you expect you might run into from decision makers, and what would you say to those objections?
Objections are always there. They often turn into good conversations too. So, lean on the evidence. Corey Ofsted, we've mentioned it in the past. She does incredible work. One study that comes to mind is 2022. She states that over time, our team and others discovered that nearly 100% of channels have visible defects. 100%. And the need for borescope inspections has become more apparent. So not to be a scare tactic, but even if we're a fraction of that 100% in our team's really on top of it, that still is a percentage point that's probably a lot of groups are not going to be comfortable with. So I think lean on studies like this, develop the case around like what Jenni basically listed out, which is really powerful and to me makes a lot of sense with a lot of supporting data. And I do think that borescopes and visuals with those can really help in the case. One other kind of way to think about this is, we obviously every department's putting their best efforts forward. It's hard, if not impossible, to work on something that a department doesn't see, right? We're talking inside the lumen, something that they can't see and they're trying to work on it. It is a very challenging endeavor. So Jenni, it was a great question by Bobby. Is there anything else you think I'm missing?
I just think the proof is in the data, and there's nothing that's better than visual evidence of this is what is in here. Like, this is what we've seen, even if you trial it or you start small, like this is what we're seeing in this bit. So don't underestimate the power of a picture.
Thanks so much for that. I hope that's really helpful to our listeners who are watching through this expert series. And we just want to say thank you for spending your time tuning into a video series on effective borescope uses in a sterile processing department. We obviously think it's very, very important. We think you should think it's important too. You're picking up here at episode 2. If you missed episode 1, feel free to check out the expert series page at Beyond Clean to see Andy and Jenni talk a little bit more about why borescopes are so important. Guys, next time we get together, let's start into that borescope process and how not only we can get one bought for our department, but how can we be most effective whenever that shiny new toy shows up in the department. So with that, we'll go ahead and wrap this episode. Again, I'm Bobby Parker. You've been watching the Borescope Expert series, and until next time, keep fighting dirty.